Today we have Dr. Sambhaji chintale with us. He is director at Cosmo Hospital and Research Center, Aurangabad. And sir, today sir is addressing us on uncommon cold. So after the session, if there is any query or questions, you can ask to Dr. Chintale sir. Yes sir, we can start now sir.
Okay, thank you, Ravi from Sipla. Thanks for giving chance to present the common topic in this season, that is the uncommon cold, which is a very common in our Indian scenario, because in Asian countries there are a lot of patients of the allergic rhinitis typically, that is the uncommon cold, presents to the ENT surgeons or most of the general physicians and physicians in their OPD. So everyone should know about the uncommon cold, what it exactly, and how we should manage the uncommon cold. The sneezing repeatedly when you are around the dust or smoke. If yes, then it is highly possible that you are allergic, or it's allergic rhinitis, which refer to an allergy that specifically affect the nose. Allergic rhinitis, unlike a common cold, is not caused by any virus. The overall, the allergic rhinitis has an estimated worldwide prevalence of 10% to 25% and is one of the most common disease in childhood, with prevalence reaching up to the 40% in the some region. The burden of allergic rhinitis is enormous, constituting about the 55% of the allergies. About 20 to 30% of the Indian population suffers from at least one allergic disease. The symptoms of rhinitis were present in 75% of the children. Allergic rhinitis is the most common type of chronic rhinitis. It is a symptomatic inflammatory disorder of the nasal mucosa. Inflammation is induced by allergen triggers from the environment and mediated by the immunological system of the body. Allergic rhinitis can also be influenced by non-allergic triggers. Symptoms of allergic rhinitis may cause other clinical manifestations such as sleep disturbance, fatigue, depressed mood, decline in cognitive function, thus impairing the quality of life and functional productivity. Thus, the allergic rhinitis should be considered as a systemic disease and should be overlooked as the local disease. How the allergic rhinitis symptoms present? Most common symptom is the nasal obstruction, which is about 48.5%. Then running nose is 33%, and sneezing 24%, and nasal itching 20%, according to the International Otorhinological Head-Neck Journal. The phenotype of rhinitis, that is the what basic mechanism is involved in the allergic rhinitis, is that allergic rhinitis, immunoglobulin E mediated allergic rhinitis, that is the inflammation of the nasal mucosa resulting in eosinophilic and the T2 cells infiltration of the nasal lining, intermittent or persistent maybe. Then other type of non-allergic, non-infective rhinitis are due to the drug induced or sometimes hypothyroidism, hormonal imbalance in pregnancy, rhinitis of the elderly patients, occupational rhinitis, non-allergic rhinitis with eosinophilic syndrome. Sometimes the gustatory rhinitis, while chewing we give the symptoms of rhinitis. Vasomotor rhinitis is a purely neuronal one. Nasal mastocytosis, then atrophic rhinitis. Infectious type of rhinitis is the viral most commonly, bacterial and then fungal. Like in the mucormycosis, we have may experiences or the examples of the fungal infection with the rhinitis. Then idiopathic. Allergic rhinitis versus non-allergic rhinitis. What the symptoms leads to the allergic rhinitis, what type of the symptoms and duration of the symptoms, and what is the non-allergic rhinitis. The symptoms of allergic rhinitis is specifically two or more of the following symptoms, that is more than 1 hour on the most days that is watery rhinorrhea, sneezing, especially paroxysmal, nasal obstruction, nasal pruritus, and sometimes may present with conjunctivitis. That is classically and assess the severity. Then symptoms usually not associated with allergic rhinitis. These are the sometimes the symptoms are unilateral. Suppose the nasal obstruction is of one nasal cavity, mucopurulent discharge, posterior rhinorrhea, that is postnasal drip with thick mucous secretions, pain, recurrent epistaxis, anosmia. These are the other symptoms of the not associated with allergic rhinitis. Then we need to consult the patient to the doctors. How the allergic rhinitis and associated comorbidity are related with each other. The 67% of the allergic rhinitis leads to the chronic sinusitis. 21% patients of the allergic rhinitis leads to the asthma. So it is a very necessary to look out for the allergic rhinitis patients and get treated properly. Otherwise, the allergic rhinitis patient get converted into the asthmatic. 21% of the patients also may have an history giving the otitis media with effusion, specifically in the children. And 2% patients with a recurrent nasal polyposis may present as when the allergic rhinitis is not controlled within the time. These are interlinked things which allergic rhinitis leads to: the nasal polyposis, sinusitis, then asthma, upper respiratory tract infection, and in children's otitis media with effusion. Allergic rhinitis is also frequently associated with asthma. It is found in 15% to 38% of the patient with allergic rhinitis. Nasal symptoms are present in 6% to 85% with asthma. Allergic rhinitis and its impact on the quality of life in day-to-day life also. Allergic rhinitis can affect the physical, psychological, and social aspect and impact work productivity. A study involving 34 Indian patients with allergic rhinitis shows that allergic rhinitis adversely affects the behavior, work performance, and lifestyle of the patient. Further, the allergic rhinitis causes the hindrance to work, daily work, due to repeated blowing of the nose and needs to rub eye and nose. Allergic disease, a tribal disease. Despite of such substantial burden, both disease still remains under-recognized, underestimated, under-treated in the Indian, because as in India or in Asian country, this is a very much common problem. Most of the people neglect these symptoms as usual, and that leads to some other type of comorbidities with this allergic rhinitis. Why we need for allergic rhinitis Indian practice guidelines? Because till date we follow the Western countries guidelines for the allergic rhinitis, but recently last 2 years the Indian Otorhinolaryngological Association formulated the guidelines for the Indian patients properly for the allergic rhinitis, rather than making the guidelines from the Western countries. They are always standard, but in Indian scenario, some we have formulated as an ENT all over the India. They collected the data from the all over the India and formulated our own Indian guidelines for the allergic rhinitis. So everybody should know it. That is the Indian guideline on allergic rhinitis by the Association of Otorhinolaryngologists of India, as we are the part of that organization in active body form. The stepwise diagnosis: first we have to make for the allergic rhinitis, that is preliminary investigation what needed, detailed history examination, physical and clinical examination, differentiating indicators between the common cold and allergic rhinitis, identification of common sign and symptom of allergic rhinitis. How we differentiate it or we judge the allergic rhinitis by symptoms. There is a nasal itch, rhinorrhea, nasal rhinorrhea, sneezing, eye involvement, presence of seasonal variation of the symptoms, diurnal pattern of symptoms, symptoms triggers when indoor or outdoor, or any trigger factor that relates to the symptoms. The personal, in pregnancy there is always an increase in the hormonal imbalance in pregnancy give rise to allergic rhinitis and congestion. In family, if the patient's family history is having the parental or first degree or second degree relatives, their allergy or asthma. Environment factor, as we know, that is the most common is the house dust mites, then pollen grains from the gardens, fewer of animals or household animals, flooring of household and molds, Then tobacco exposure, humidity level of the rooms or homes or in the environment. The occupational exposure, specifically the industrial smoke, cotton, asbestosis, chemicals, latex. This is specifically in the tier 2 or tier 3 cities where the lots of industrialization takes place around the cities, which give rise to this type of occupational exposure leading to the allergic rhinitis. Some medication may also give rise to the allergic rhinitis, that is or allergic symptom. Beta blocker specifically used for the antihypertensive patient. And then aspirin, non-steroidal anti-inflammatory drugs, angiotensin converting enzymes, inhibitor drugs for the hypertension patient, hormonal therapy, recreational drugs sometimes may give rise to the asthma allergic symptoms. Then related comorbidities like the mouth breathing, snoring, sinus involvement, otitis media, nasal polyposis, conjunctivitis, hyperreactive airway diseases, and skin allergies. Then responses to the previous medications sometimes lead to the rebound allergies, that is antihistamine, intranasal corticosteroids, sometimes nasal nasal decongestant. Component of physical and clinical examinations. Physically, we differentiated the patients of the allergic rhinitis by seeing the allergic salute, that is repeatedly putting the hands over the nasal tip, that is allergic salute. We call this is allergic salute. Then horizontal crease over the dorsum of the nose. Over the dorsum of the nose, here we get the horizontal crease because of the repeated nasal tip elevation. Sometimes the patients may have mouth breathing, specifically in children. Allergic shyness, there is a dark circle below the eyes, that is allergic shyness we call it is. Frequently sniffing and throat clearing, this is the symptoms most of the general physician or ENT practitioner look for that. On anti-rhinoscopy or nasal endoscopy, specifically by the ENT surgeons, we see the mucosal swelling and bleeding. Abnormal secretions may be pale or thin, polyps or other structural abnormalities. On sinuses, on examination, there is palpation of the sinus for signs of tenderness. Maxillary sinuses, we have to see the tenderness over the, this is our canine teeth, over the canine fossa, we see for the any maxillary tenderness. Then maxillary tooth sensitivity we can also judge. On clinically posterior oropharynx, we have to see the oropharynx. We see the postnasal drip with a whitish discharge coming from the nasal cavity posteriorly. You can also see by depressing the tongue with tongue depressor and see for in nasal discharge. Then lymphoid hyperplasia, cobblestone appearance is seen in the pharyngeal mucosa or lymph nodes that get enlarged. Then we see the tonsillar hypertrophy if there is a repeatedly involvement of the tonsil by the sinus secretions behind the tonsils, which give rise to tonsillar hypertrophy. Chest and skin examination, sometimes there may be atopic diseases over the skin, which we have to look for, and wheezing on auscultation of the chest. These are the clinical details of the how we can examine the patients of the clinical allergic rhinitis. Where are you experience the most irritation or aches? We have to ask the patient whether it is eyes or throat or body. Are you experience the itching in these areas? If the patient say yes, then it is always an allergy. If patient say no, your symptoms described symptoms occur seasonally for long period of time. If yes, then it is an allergy. If no, then it is a common cold. When body aches or have fever, yes or no, or depending upon symptoms, how are your symptoms get best described as? Symptoms come of fast and taper quickly, that it is common cold, and if not, then it is an allergy. This is the differentiating points commonly. Common cold is associated with fever. Allergic rhinitis is not associated with the fever. Only uncommon cold, is it cold or allergy? How to differentiate? The cold that is remain for 3 to 15 days maximum Allergy it remains days to months depending upon the exposure to the particular allergen. Time of year, common cold mostly it is seen during the winter, but maybe sometimes present at any time. Allergy is seasonal also. Onset of symptoms few days infected after by the virus. Allergy it can start at any times when the exposure allergens comes in contact with the body. Coughing is always there in the common that is in common cold. Coughing is not in allergy. Sneezing is often in both conditions. We cannot differentiate where the sneezing is present. It present in both the conditions. Body ache never cause in allergic rhinitis, but in viral infection it gives rise to malaise and then fatigue. Seen in common cold. Fever is rarely seen in allergic rhinitis. Fever usually seen in common cold, not in allergic rhinitis. Itchiness, watering eyes is a common symptoms in the allergic rhinitis, not in common cold. Sore throat, specifically in the cold viral infection. Runny nose seen in both allergic rhinitis and common cold. Then identification of common signs and symptoms of the allergic rhinitis. Classical symptoms of the allergic rhinitis are these four. Everybody should know as a physician or general physician. Sneezing is always there. Running nose, nasal congestion, itchiness of the nose or palate, and watering from the eye. These are the cardinal symptoms of the allergic rhinitis. The features of sneezer, that is runners and blockers. Blocker is specifically seen in sinusitis as a symptom that leads to the blockage. In sneezer, sneezing is especially paroxysmal. Rhinorrhea, watery or anterior or posterior nasal discharge. In blockers, there is a thick mucus, more seen in posteriorly, not anteriorly. Nasal itching seen in sneezers, but not in blockers, specifically when there is a sinusitis. Nasal blockage is often seen in sinusitis patient, that is blockers. Diurnal rhythms worse during the day, improve during the nights. And blockers, there is constantly symptoms present in the day and night and worse at the night. Conjunctivitis is often present in sneezers and runners. Then common clinical investigation in allergic rhinitis is the clinical symptoms are always important. Along with that, skin prick allergic test is done specifically at some centers. Then cytological examination sometimes we do as nasal smear for immunoglobulin E specification or eosinophil counts in the nasal secretions. Allergen specific immunoglobulin E testing can be done. Blood counts, differential count, peripheral smear specifically done. These are basic routine tests, and there are some differential diagnoses you should all know. Autonomic rhinitis, that is vasomotor rhinitis. Then drug induced, we have to ask for any the antihypertensive drugs or other medication is in using the patient. Hormonal, we look for the thyroid conditions of the patient or pregnancy. Sometimes congenital diseases, that is cystic fibrosis, may lead to the polyposis allergy in the children. Immunodeficiency state, we have to know from the patients. Sometimes malignancy, patient having bleeding, pleural discharge, pain and nasal blockage. Structural abnormalities, we look for the DNAs, nasal polyps or other any nasal pathology. Then local conditions, we have to look for the skin and serum immunoglobulin test are negative, but positive response to the nasal allergen can be leads to the allergic phenomenon. Idiopathic condition may be present there. Specifically, sometime the rhinitic symptoms non-allergic rhinitis symptoms or non-infective pathology when the patient eats the spicy foods like the capsicum. Then there is an symptoms looks like the allergic rhinitis. Then recommendation, diagnosis, differential diagnosis, we can all know about this: allergic laboratory test, skin prick test, nasal test, smear test, immunoglobulin testing, then and immunotherapy testing for the patient specifically for any specific allergen. Now the grossly we came to the treatment. Treatment is everybody know what to do, when to do, but some guidelines have there to when to start few specific medications and when not to stop. Everybody we prescribes each and every molecules accordingly the symptoms of the patients, but there are some guidelines formulated. We can see this chart so that everybody should get the idea about it. Recommendation treatment approach for allergic rhinitis is that step down and step up therapy for the allergic rhinitis specifically. Step up therapy if poorly controlled. What we should have to do: avoid the triggers of the allergens. Specifically ask the patient to wash the nasal cavity by saline or by nasal douche using alkaline water, by home remedies, or there are formulations came in the market now since last many years. You can advise them to nasal wash when the symptoms are not controlling their step up therapy. Step down therapy when the symptoms are mild. Specific immunotherapy has to be started in the last. What one should start: antihistamine, as we know, we give as in first line of treatment, oral or it may be intranasal antihistamine first line of treatment. Then start nasal corticosteroids. Then in addition, if required, we have to start the leukotriene receptor antagonist and the nasal corticosteroid. That is third steps. And lastly, the immunotherapy, if the availability is in a nearby you or nearby your specific center where the immunotherapy given to the most of the patient when the all our medications do not give relief to the patient. These are the few symptoms where the effect is seen in the early on antihistamines, corticosteroids, hormones, decongestant, anti-allergies, anti-leukotrienes. This is the chart specifically for all the physicians and the general physician. What we should know: the line of management on all type of allergic rhinitis. When there is intermittent allergic rhinitis and persistent rhinitis, they again divided into the mild and moderate to severe, and persistent again divided into the mild and moderately severe. In mild, we all know. In intermittent rhinitis, we as know we start antihistamines, that may be oral or intranasal. Then we have to add the leukotriene receptor antagonist like montelukast in that. And lastly, we have to start the intranasal corticosteroid, whatever formulation available with you. And specifically when the symptoms are moderate to severe, more than 3 weeks, 2 weeks, then same line of treatment, but we have to add the intranasal steroids before the leukotriene receptor antagonist like montelukast. And also again we have to add the decongestant nasal xylomist or oxymetazoline preparation. In persistent allergic and means continuous, when the symptoms are mild or moderate, again we have to divide it into that. In that persistent symptoms, we have to add as a first line of drug treatment is a nasal steroids. Then simultaneously we can give oral antihistamine or intranasal antihistamine. Then same, if the symptoms not relieved, then a montelukast combination, and then nasal decongestant we have to add. Same in that mild non-blockers, when the sinusitis symptoms are more there, oral antihistamines, intranasal corticosteroids. Again, same leukotriene receptor antagonist and decongestant. Formulations are same for everywhere, but when to start as a first line or when to start as a second line, we have to differentiate this depending upon the symptoms and duration of the symptoms of the patients or severity, mild, moderate or severe. We have to just change this. It is not that much complicated, just only why we know the antihistamines, intranasal steroids, oral steroids. These are the three basic lines. But when I start as first choice drug or second choice drug depending upon the allergic rhinitis symptoms and their severity, just we have to change formulation up and down, up and down. This is all in details, but clinically we have to know depending upon the history and symptom of the patient either it is allergic rhinitis or not. The patient mostly tells about that what he is feeling like, that allergic rhinitis or not common cold. But as a clinician or physician, we have to examine the patient properly and we have to classify the patient accordingly or our knowledge and symptoms. Then these are the steroids therapy when we started, or we have to complete it in allergic rhinitis specifically for 1.5 months, sometimes 2 months, sometimes 3 months. Depending upon that, the dose we have to monitor and taper. These are the same drugs, and if the patient is having simultaneously the allergic conjunctivitis, then we have to give the saline wash and intraocular sometime H1 blocker drug is given to prevent the conjunctivitis and itching of the eye. Lastly, the unmet need in the diagnosis and management of allergic rhinitis therapy is that education of clinician to enable them to differentiate between the common cold and allergic rhinitis. It is a priority basis. Then, as always, patient awareness is needed, and making the standard algorithm whatever you are having with guidelines like the Indian Society has Association of ENT has put for Indian people. You should keep in mind that, or you should keep the guidelines chart in your clinics so that you can overlook it and advise accordingly the symptom of the patients. Thank you so much. Thank you, Ravi.
Yeah, really, thank you, sir. Yeah, thank you so much, sir.
Yes.
Thank you all participants. Today we have Dr. with us. Any question?